But indeed, that is the reality of where we are. We've also talked about age. We talked about how the Generation Z relate with life and with work, irrespective of whatever work it is. So again, that impacts on how they deliver at work as well. We've talked about, for example, apart from the aviators, and we still consider them as aviators, people who work in technical. So the people who make, let me call it the mechanics of the aircraft. Again, it is up to them to make sure that everything works. And that person who brings, whether they're hypertensive, whether they have cancer, whether they have their grandmother who's unwell, those are the people who come to work and make the wheel of aviation keep moving. And therefore, from a KQ perspective, or from any organization perspective, that you look at the wholesome whole of that person, whoever it is, irrespective of the machine. But of course, then the complexity that comes with the machine means that even if we are not having fatal accidents, it means my ability to do the work as a human within KQ is dependent on those very many factors. My work design, my occupation, my work environment in which that I'm working, of course, the salary that I think I am getting, my relationship with the person. So you can see mental, financial wellness all comes into place. So today, as we discuss, I think for me, one of the things when I thought about this panel is how do we look at that person? Now let's focus on the person as a holistic person in terms of aviation, which is where you come in to make sure that we keep our skies safe. Thank you.
It's the pilot who is coming to fly an aircraft and he comes to the cockpit worked up. That human interaction with the machine, while he still has hangovers of what happened at the gate, brings aspects of his mental well-being in the cockpit. And that can be a factor which can affect the performance of this person. As I said earlier, the focus in aviation medicine is the aviation-sensitive personnel, and in particular the pilots, the engineers, and the crew, among others. And human beings, as I said, are wired to operate on land. But when they get into the skies, they are exposed to limitations of being human. Limitations in terms of pressure, limitations in terms of oxygenation, humidity, and the like. Like probably if you operate in an aircraft, most of them are pressurized to about 8,000 feet above sea level. That is equivalent altitude inside a normal pressurized aircraft. In there, the oxygenation levels are low, around 60%. Humidity also around is affected. So a person who will do very well on ground, when they get into the aircraft, will be limited in what they can be able to do. And that's why you see if some passengers carry eye drops to hydrate the eyes, they get dry eyes. You can imagine if this is the pilot who gets a dry eye and is having an emergency, he's supposed to be landing, but he's being irritated in the eye. That small thing will affect this particular guy in performing that particular crucial task, which he's doing at that phase of flight, which is not his normal environment. So when you talk about the human factors, they go all the way from the ergonomics inside the aircraft, his state of mind, and all that which makes him operate at maximum while operating in a different environment from what he is supposed to be. Thank you.
What are the most pressing mental health challenges affecting pilots and cabin crew? And how can aviation specialists balance supporting well-being while ensuring flight safety?
It is true, mental health is a big thing in the modern world now, unlike in the past. It is not just because the population has increased, it's not just because of industrialization. There are more factors beyond that, including the resilience that the young people have now as compared to the past, etc. But to answer your question directly, it is true. The aviation industry is a high-pressure environment. The jobs are very high-pressure type, and therefore stresses are sometimes leading to depression, sometimes leading to complete mental breakdown in that order. It is true. There are few who have had to have interaction with the psychiatrist and with the psychologist. And I had Dr. Ilako here before he left to mention that they don't come with the friendly face and they are not happy. If there is a place they come without happiness, is to me as a psychiatrist. Because first of all, they come with that attitude like, I don't know why I'm here. You're a psychiatrist. I'm like, yes, I'm a psychiatrist. I'm not mad. And I'm like, of course. And who said you are mad? Because that is a question that you've been sent to a psychiatrist because you are mad. But we work very closely with the psychologist, and we are able to pacify and to be able to explain, and to, when the indications for admission, when the indication for medications, we have to work with them and work with the industry, because these are regulated industry. Therefore, you cannot work in isolation. Of course, it has consequences, because you may not be able to be fit to appear to the AMA, or therefore you are grounded. But it's for your good and for the good of the public, especially the unsuspecting public. Because as Dr. Muida was saying, out there, if you are the passenger, you want to imagine that your pilot, the crew, they are top notch in their mental health. But the other thing that we need to be alive about is the stressors that come because of where you are coming from. He has mentioned about the gate. But imagine that airman who is coming from a home with stressors already. So irritated by this, it's not a traffic jam, it's not the spouse, it's not this or that. Therefore, the home front stressors, they are real, they contribute. Financial issues, major issue, especially gravitating towards substance use. So yes, psychological issues, anxiety, stress, anxiety, depression, in that order. I would obviously begin with the good work they do. We are very grateful. But when you refer patients to us, it's always good to have a word with them, because sometimes it's very difficult to begin the interaction when they don't know why they've been sent there. There is no harm. If you feel they have a psychological issue, be real about it. It is true, they need help, and it's about them. We are trained to be able to pick psychological issues, and many of the doctors do pick them and advise them accordingly. And that's where it begins, because this is an awesome person. Therefore, it's not just it's gynecological issues or it's diabetes. They are interrelated issues that once you pick them, you begin from there. To prevent worsening or appearance of these issues is about education. And there are stress management techniques that can be taught to the employees. And this is mostly the work of the psychologist, and they are able to empower them about the tips of mental well-being. And they are able to give them tips of what to observe and when to know there's a problem, so that you don't have to wait until things are bad. Unfortunately, for mental health issues, sometimes when the sufferer may not know. In fact, the colleagues are the ones who see behavioral change, because there's no swelling per se that you can pick. There's no limp, but the behaviors. And this is why it is important to be our brother's keeper, our sister's keeper, because you work with this person a lot, you know him, then all of a sudden the behaviors are changed. Either way, whether if you used to be a talkative person, he doesn't talk, or if you used to be very talkative, not talkative now, is the chatterbox, there's a problem. It's about change. And once you see a drastic change, then there may be an issue. There may not necessarily be an issue, but there may be an issue. And this is where each one of us can come in to see. I think you may need to see the mental experts. Maybe not have to mention the psychiatrists. That's what they fear. The mental health experts, and just have a check. The way you tell people, go have a check. Your BP, your passing, your what? It's the same. We can also start from there. So once you see behavior changes, things that are not adding up, ask them to have a mental health check. And that may be a good entry point, a good beginning.
As passengers, we know how we struggle when there is turbulence. Well, I struggle. I have prayed several prayers and promised God a few things while I'm up there. So you can imagine this happening. And this is your everyday environment, yeah? What happens to that crew? So Doc, thank you. You've mentioned fatigue, you've mentioned stress. But maybe, Dr. Mai, fatigue has been identified as a key contributor to aviation incidents. From a medical standpoint, and as the head of medical in KQ in an aviation space, how does fatigue impact operational safety?
So many facets. When you think about fatigue, particularly in aviation, we worry more about the pilots because they sleep pattern more than the crew. But also remember they do long hours. So remember the aviation industry is a 24-hour sort of economy. So irrespective of where you are, whether you're the security guy or whether you are the guy in cargo or whether you are at the control tower looking, I remember that in KQ somewhere along the line through occupational health, when we looked at OCC, which is one of our control centers, and wondering why they tended to have, we realized that because they tended to observe from the, and a number of aviators who've been at a control tower, they tended to stand for up to 6 hours straight up. So things that you don't realize many times unless you go on the ground, because they'll just complain about the backache. So what we are seeing is increased activity around physio and more activity around the orthopedic surgeon. So being able to interrogate, what that fatigue would look like. Many times it's related because of circadian rhythm or lack therein of particularly pilots, especially the young people who then are not really following the pattern of sleep. So they're sort of awake several hours. Just like doctors, I want you to remember when you used to be in Kenyatta or Moi, that when you go to the hospital, you realize you don't have an office. Your work is such that you go and you see the patient, and then you go home. So when pilots are not flying, what are they doing? Yeah, so the downtime of between rest period and what have you means, of course, they'll be either indulging in activities that we don't want them to, but also it means that they're not getting the kind of rest, because human beings don't sleep sort of round the clock, whether you travel or you're not. But anyway, so in terms of fatigue, what we have seen in the industry is people actually complaining. And I think some of the AMEs have been, alluded to that. And it's good when you do tell us back that we are having concern. And they'll say this, the safety department will come and they'll be able to stipulate to you that they're very particular, it's regulated, how many hours are you taking, how many are you sleeping, how is it arranged. But unfortunately, when you come to the person, for example, I know that while we might say it is okay to fly in the local, they're going up and down. So going to Mombasa, coming back, going to Kisumu, coming back, is much more laborious for many people than having a long haul flight, so to speak. So as they're coming to present, it might look like, no, maybe you're flying too many hours, but the rota will look right, let me put it that way, but there are many other things. But remember that again, you go home to several other factors. So I think for us within the aviation, we have seen, especially of course during high peak, when we do notice, and of course related to that is our people management, leave management, and everything else. But many times what we have seen in terms of fatigue management, assuming that the safety is compliance in terms of the rota and everything else, comes back to the individual. But how do we teach our staff to be able to raise their hands when they're feeling out of sorts? But as we're talking about aviators, because we're 12 hours, we see that because of disruption. The aviation is a very disrupted. So you go to work for 8 hours, but you will leave at midnight because the plane delayed or whatever the story might be, or you are delayed landing, whatever the story might be. So that impacts, and usually we see it now eventually at the psychologist or Dr. Ndegwa. Why? Because people don't notice it until it is way down the lane. So either they're drinking, or we start seeing absenteeism, and then we start seeing mental related issues. So I think for us as medical practitioners is how do we, again, coming back to looking at the person holistically, but also sounding it back to the organization, please relook at your rotas and see where there could be an issue. We did have a complaint or a feedback, from the AMEs regarding people who are doing 737, that they had a particular complaint regarding their backs, for example. And today when we will go to the aircraft, it's not a 737, it's a 737. But one of the things they did realize, when we think of economics, we don't replace seats in our car, do we? So we don't think of replacing seats in an aircraft. But they did realize one of the things when we looked forward is one of the pilots did say it's the way they sit because of the wear and tear, and they tend to sit like this. Okay, now when you go to the simulator, if you are doing what you'll see, what the actions, it means that after some time I'll have a problem with my back. But also I'll be fatigued because my work design is not is the way it's supposed to be. So we are seeing the actual issues of fatigue. So they might not at the moment appear that it lead to accidents, but it's decreasing performance and productivity and impacting on the industry, but it's also affecting our sick leave index because I'm too tired to do anything. You know, of course, we need to interrogate whether there are other issues, but from what is within our control as an organization, there's an opportunity to work with medical providers to help us to identify what are those patterns and commonalities, coming back to what you're saying in terms of research, to be able to see, is this something that is common in the industry and what do we do about it? Thank you.
Easy. So we keep trying to come up with these names, but the truth of the matter is mental health continues to be, a bit stigmatized and people are not comfortable with it. But we see the risk it carries when it comes to aviation. So how do we balance the medical confidentiality and safety? And for you, Dr. Muinde, this is a fundamental ethical principle, the medical confidentiality. But in aviation, we are saying safety is paramount. How do aviation doctors navigate the fine line between protecting patient confidentiality and ensuring public safety? And then I'll just ask you to hand over the mic when you're done to Esther so that she can tell us from a systems and data perspective, how can technology support this balance?
Clients can be able to open up to you. You create the environment to be conducive for you and your client to be able to at least give you information which is only for you and the client. Also storage of our documents in the clinical rooms, in the rooms where we examine them and see them, are also stored in a confidential manner. In fact, we do audit of the offices. We visit the offices before we can be able to license the AMEs to practice. We visit the offices and see whether they have storage for the medical documents. Again, the transmission of the documents to the Civil Aviation Authority, again, is also, the chain is maintained, even the storage at the KCA. The custody is still maintained by the medical personnel. But where the issue comes is now between the regulators, the clients, and the AMEs and the CMA. Those are too many people, and any conduct has a trace. So there's a lot of conduct of quite a number of people who are supposed to be communicating for aviation safety. Sometimes it's not forthcoming, sometimes it comes, you can't get it fully. Dr. Maya wants to tell me something about a client in Kenya Airways who was seen by Dr. Feni, but Dr. Feni has not told Dr. Maya. Dr. Maya has not talked about it, but she has told, she wants to tell me, and she waits initially to see how I will react to this semi-information. So it's a web which is entangled and needs to be sorted out probably. That's why I land over the mic.
Thank you so much, Dr. Muinde and Dr. Eva. From a system perspective, ideally is to ensure that aviation doctors use systems that comply to regulations. Yes, we have HIPAA in the US. We have the GDPR within the European Union. So the key thing that we highly recommend for all the smart systems, we've been able to comply with the GDPR rules, which really states on how the data is provided, be it a patient data, that the patient must consent in terms of their data being provided to either a particular doctor, being able to really encourage systems that allow for patient portability in terms of records, which also comes within the smart system, to ensure that indeed, if Dr. Muinde here has seen a patient today, but tomorrow they are referred to Dr. Mai, must they be able to repeat all the tests, or can they just pull a record from the system and see, indeed, Esther yesterday was at Dr. Muinde, these were the tests done. So we have been able to ensure that within the smart system, can be able to call up a record of a patient and even be able to go and say, I want to see consent. Of course, consent must come from the patient that indeed share my record with Dr. X, Dr. Y, Dr. Z. What we've done is to ensure that the systems where we are smart, our systems are fully compliant. They've been certified, and we have been certified as a data processor and data controller. Let's ensure that indeed patient records are provided and are stored in the highest standard of security. And only, for example, an aviation doctor can only be allowed to disclose information where it's legally required, probably by law, or where the actual, be it patient, be it crew, is a condition that really requires for them to disclose, otherwise there will be a safety concern.
Maybe you can just shed a bit of light in terms of how we are navigating that space when it comes to the role technology is playing in aviation medical evaluations. Are we really, have we really exhausted that space? We're still very manual, you know. Maybe you can speak a little in where we are right now.
But we have taken the first step because, as you heard from the medical assessor from Kasoa, they've already implemented some bit of it in Tanzania. Burundi and Uganda are training, and Kenya already the tendering process is through for use of technology in medical record keeping and data analysis. So I would say that we have learned from the past, and we are moving with technology, and very soon indeed, because even next week we'll be training on the same system so that we can start implementing it in Kenya. I know there will be some resistance from portals that we know, but the people who have already applied it will tell us where this resistance came from and how they have been navigating around it, and we'll be able to surmount it, I'm sure.
It's good. Sleep physiologically, you know, melatonin is produced during the dark period, nighttime. So, and the sleep is not just about quantity. Sleep is both quantity and quality. So it's only that the industry, the aviation industry, cannot be able to operate within the timelines of daytime and nighttime. Therefore, we have that problem. It will live with us. We have to adapt to it because that's how it can only be. Having said that, when in the absence of anything else, if you can't go to sleep at night, then you have to sleep when the time is available and it's there. When you are traveling from east to west, it's worse than when you are coming back this way. But luckily, most of the time you're going west, so you're coming home. It's easier for you that way, as if you want to adjust. Unlike when you're going the other way around, because now it's like you are chasing the day, as it were. So I wouldn't be able to say what else can they be able to do. They can only be able to do with what they have at that particular time, because there's no other option.
Thank you, Dr. Eva. In terms of what can we be able to do, we are very strong in terms of partnership, collaboration. In terms of sharing data across Africa, we do work with over the 12 countries where smart in operation. Of course, we've had working with airlines, KQ, for the last over 10 years. Other airlines in East Africa, you know, Rwanda, you know, Uganda Airlines, all use smart. So in terms of collaboration, how can you be able to see? How can we work together with civil aviation in terms of just ensuring that the doctors really comply or are using standardized systems that can be able to easily now provide this information to the society, to the authority where need be. Ensuring that indeed there is a standardized method of reporting. We are very big in terms of standards, complying to, you know, ICD-10, ICD-11, to ensure that indeed when it comes to passing information from where it is carried to where it is being delivered, it's able to have the doctor understand in the same language because it's following standard as opposed to separate systems not being able to handshake and speak to each other. So indeed there are multiple areas in terms of using technology that we can collaborate, and more so very big in advising and providing analytics. You know, what are we seeing within the aviation industry? You know, what are the, I know that one of the key things that was mentioned earlier by Dr. Alex was in terms of, can you reduce that time for a pilot onboarding telemedicine? You know, they don't have to really go to a physical facility. Can you be able to implement telemedicine, teleconsult, prescription? Because we've seen that indeed 60% of an outpatient visit actually goes to medication. Yes, it has been confirmed, has been. So for a doctor, for a pilot, if they can easily just call to the smart system on different platform, consult a doctor, get their prescription either in their house or in their office. That will reduce the time they'll take to probably travel from their home to, you know, their place of work. We can be able to look at these particular areas. Collaboration, of course, approvals, because it's medical data, it's legal data, with the required that we can be able to see, can we be able to share this across board?
Thank you.
Doing, and it's also a factor of day and night. That's between Nairobi and Mombasa 4 times. I can do that during the day comfortably. But at night, that is restricted to 2. So the number of sectors reduces at night.
Thank you for taking from here. Yeah. So thank you very much, Captain and Paule, for the ambush. But we're glad you could make it. So we've come to the end of our panel discussion, and you've seen we've tried to discuss different topics. We've gone from the human factors, narrowed down to fatigue, to stress, to confidentiality, to the data protection, the role of technology in care. But I'm sure you do agree that that collaboration between the medical professionals here, the pilots, the safety team, by the way, my apologies. Captain Haig is the Director of Safety in Kenya Airways. Please clap for him. That was an oversight of protocol in my case. And technology is essential in assuring aviation safety and well-being. So I'll welcome your questions. We'll just take about 10-15 minutes.
Night duty. So with those restrictions, we believe that those are sufficient enough to assist you rest and be ready for the next flight. So those restrictions are there. For Dr. Mwinde's question, so it's a very difficult one because when pilots have reported fatigue and we send them to Dr. Mae for review, and then Dr. Mae says, yes, this person is fatigued. So what we do is we look at a statistical analysis of your roster for the last 6 months, 3 months, 1 month, and 28 days. And when we look at that roster, the pilot has done 40 hours a month. So the question is, what activities have they been doing to create fatigue? So we have a maximum of 105 hours, but they've done 40 average over that time period. So it's to now question what other extracurricular activities have been going on to cause this particular fatigue, because it could be sleep issues, it could be a lot of other issues and family issues. So usually when we've done that analysis, we'll have to send them to Dr. Mae because that needs a medical intervention. So yes, you're fatigued. We can't see it in the roster, but we're not sure why and what's going on. For duties that are within the roster period, so what we've done for pilots, we've been able to give them an opportunity to rest on board. We call it controlled rest in flight. So we allow you to nap. Now, I'm not sure that's a good thing to say out loud, but we allow you to nap, but it is in a controlled fashion. So there's a maximum nap time, so you can't nap longer than that. And then the pilots became creative, so they could say, I want to take 4 consecutive naps, because the naps have a maximum time. So you could find they are asleep for 4 hours. So you're only allowed 1 nap in flight. It's timed. You have to let the other person know. It has to be at a time where there's no workload, the weather is clear. So the parameters for that, the cabin crew has to be notified when you're starting, and after 20 minutes they come back and wake you up. So if it is in the roster period, in the duty period, we have interventions on how to control that fatigue at that point. But how do we control what pilots are doing? I think we've agreed, Dr. Mai, it's just more around awareness. You can agree that if I tell you to go and sleep now at 2 in the afternoon for a flight that is at midnight, that's very difficult for you to do, because you need blackout curtains, you need an environment that creates sleep opportunity, which is not very easy. I can't audit where you live. If you live in Kayole and you're a pilot and there are matatus, there's a road next, there's all those factors that we can't really control, but we can only educate you. So ours is more of education. We would like to publish a sleep schedule. So if your flight is between this time and this time, we recommend that you sleep at this time. And in the ops manual, there are conditions for what a room should look like, how it should look like, the temperature, and all those things. So we can't really interfere with the pilot's life to that level,
because there are very many, and it's just not possible, but just to urge them to rest. From a safety management perspective, we do expect them to report. So when you report fatigued or you feel that one of your colleagues was fatigued, we've had cases where a pilot has reported another pilot that they were asleep for most of the flight. We would have a discussion with that person. So from a safety management perspective, those interventions are there for us to be able to capture this data and see what's happening in this group of pilots and cabin crew.
Maybe an addition to what you just said, or maybe a question. Do you have missed opportunities where you said you refer them back to Dr. Mai, but I see an opportunity on your side also when you are doing the crew resource management training with the data you've collected over time. You've seen the number who are given enough rest time, but they didn't rest. They were fatigued and reported. Do you get opportunity to discuss with them now as crew members, as pilots? You discuss with them from your perspective why they need to rest, because you are seeing 1, 2, 3 things, so that they also see that it is being seen and they are hearing it from a colleague, not a doctor. The moment you send them to Dr. Mai, they take offense, I can assure you. They take offense and they start fighting with Dr. Mai instead of listening to a colleague. The other thing I've just forgotten, I'll remember. Yeah, I'll remember. Maybe I'm fatigued. Yes, sorry, Dr. Ndegwa. Sorry, sir, I'm asking so that I shoot myself again. Is there an opportunity for any sleep pills which can be used? I know Zobidam has been used in the fighter pilots in war when they are expected to fight, and there's no spare fighter pilots. When they finish the duty they are given, they sleep for a while, and they go back to duty. Is there a chance that happening in Kenya Airways when they have less crew and they can take the drug and have good rest and go back to flying, or it's a no? It's a no-go.
The extremes of the military that can apply. I mean, it's war. Something just continue. The battle is on, so there is no other opportunity that you can have and the luxury of anything else, but not in the civil aviation. No, there's no pill, sleeping pill that is permitted. Not Zolpidem, not Zolpiclone. No.
You are put on standby. Do you count that standby time as time of rest or time on duty or duty time?
For 6 hours, for example, we give credit for duty for a portion of that 6 hours. So if you are to be called on standby, it would assume that for those 6 hours you are on duty for half of that time. So 3 out of those 6 will be counted into your duty that you've been called for. And that's why you'll find when I've been on standby for 5 hours, calling me to go to London is impossible, because I've already accumulated a lot of that time at home sleeping. But I'll just mention that I think the new regulations are a bit more progressive, because they are now very explicit that if you disrupt my sleep, you have to give me a rest period afresh from the time that you disrupted my sleep. So that prevents the airline from interrupting sleep at their convenience.
Dr. Wachira, about the question. So that is some of the things that we continue to find out. So that was established about the 6 and 737 for the older aircraft. So that is something we'll be looking into. Now, the question on whether they put on, and I really should have put that, is that the safety is very particular. When you go to, of course, you're an aviator, so you know the spaces. So when I start putting cushions and it changes the whole dynamics of the design, and it's not supposed to be there. So you'd have to get exceptional approval. What many times Hague would tell me, please sort out the medical issues and give me because you can imagine if you see a pilot flying with, say, a neck collar, what that would look like to us. So the question then is, then we start looking into what maybe we don't do as much over here is, and we don't want to retire, it's very expensive to get a pilot, but you start looking and seeing how do you get this person better, and if we can't do anything better, what are our options with physio, whatever other additional support. I know a few times you see pilots walking around with 1 or 2 cushions, but I'll tell you from a safety perspective, that they're not happy about, because it changes the whole dynamics of how you're flying when you're flying. Now, whether you get a lumbar corset or not, there are many other security, safety dynamics that come into it, and then that would fall under safety. So it now moves from just a medical. It is give us a pilot who's healthy to get the job done. Other than the other dynamics come into place, and pain syndromes and everything else that comes with because you are disposed. And it happens many times within our pilots as well. I was going to say, in terms of also the fatigue, and Haig has talked about it, is also acknowledging for our young pilots or even the older pilots, therapy is not psychiatry, but having sessions about people, because those are difficult sessions. We're not trained as doctors many times to counsel people. Not like you deal, you need to sort this out. That's the most we will say. But yet, psychology is becoming a more and more need I've seen within the workplace, where you have conversations that require clarity and a direction, and a psychologist will have a very different discussion on, are you really moving away from, it's not fatigue, it's not the workplace, it is not what you're sleeping, but it's because, you have all these other social obligations, for lack of a better word, and a therapist creates an opportunity for you to speak it out, and hopefully, because those are intelligent people, to be able to get it out. But many times, as Dr. Ndegwa said, we find it difficult to start saying, go and see a psycho. So we start saying, maybe you need to have a conversation or some clarity. So whatever we want to call it, I've seen that we have sent out a number of staff to the psychologists for them to get some clarity over what needs to be done and to be guided and change their lifestyle over whatever needs to be changed. Because sometimes it's all in the mindset on what needs to be done. And of course, a different mindset around people who are also doing alcohol. So yes, that's on course, and the team from us, Dr. Yuki from our occupational specialists, are looking and seeing what do we do. Do we need to start getting back to the 737 people to see to remember to pump up the seats again? Yeah, so that's something that people don't think about, and we just move on with it. And it's only after people realize after some time, there's a 737 pilot, there's a 737 pilot. The impact of a pilot having acute pain means 6 months he'll be away from duty. Yeah, because of pain or whatever. So yes, we will have to get through safety, the underlying issue. So that is now something we discovered in the coming weeks. I think the other thing you also talked about was the doors of 737. And the people who are opening the doors, again, it comes to how are we training people as occupational specialists to open that door, and etc., your weight and everything that comes to it. And therefore, as we say, moving from the regulations to bringing it home and actually seeing it creates a very different space. From an occupational health therapist, for example, I realized the equipment operators, they drag the plane. They literally go and bend over to collect the tail of the, I don't know what it is called, captain, and push it out. But that thing is not 2 kilograms. So if this guy keeps doing this, that's not even, and then we won't remember to necessarily train them on what, because it's, the lower there, you don't train, specifics as much. But of course, 10 years down the line, what do we do? So moving to really looking and understanding, but also when you see the patients, what are those patterns, and feeding back to us to be able to engage in different conversations. So I think I'll stop there, but maybe now that Haig is here as a director of safety, whether there's any insights from your interaction from whether the pilots or from the safety office, but particularly the aviator, that you want to tell this team, and not just aviation safety, but also this industrial safety. There's the pregnant women and technical that worry about their reproductive health. So maybe 1 or 2 comments. Sorry, Eva, for doing that. Thank you.
The performance of the particular pilots, and for us, from an output perspective, specifically for pilots and cabin crew. So you will know a pilot or a cabin crew has an issue when they fail an exam. And when they fail an exam, because exam failures in this space means that that impacts your career, right? So what the pilots and the cabin crew will do is at that point raise their hand and say, I have a problem. And they say, I have a problem at home, I have a problem, I've not been focusing at work, I've not, there's a myriad of issues. Now, of course, Dr. Mai thinks usually that's a mask for the failure, because if you didn't fail, you'd never have brought it out, right? But that points out to people are going through some sort of issues outside work. Yes, we do acknowledge that some of those issues are also around the workplace itself. And of course, the airline, through medical and safety, tries to bridge that gap and ensure that the risk is mitigated. How we look at everything in the airline is potentially about risk. So what is a risk to the airline? We would love to think about our employees more, but also from where I sit, I'm looking at risk to the airline. So I'm not looking at risk to the people, because that's maybe for the chief people officer and Dr. Mai to worry about. But for me, it's around the consequence of whatever issue it is for the airline is very catastrophic. Yeah. So one of the big main issues is mental health, and mental health is not a tangible thing that we can actually say it is brown or white or black. But from a medical perspective, I think Dr. Mai has talked about, it's about having the critical conversations with the pilots as they come to see you, or the cabin crew, or the equipment operators, about what are some of the issues that we are seeing, because 50 to 70% of the issues are around the home and what's going around in that space. That's a space we cannot interact or interfere with as an organization, as an airline. We can't go that far, but it's just to create that safe space for our pilots to come and say, or our cabin crew or our employees to come and say that there's an issue here and I need some sort of redress. So for me, it's just around the concern that the medical, or rather the mental health issue, might not necessarily be something that is top of mind for us, especially in aviation. I know based on the regulation is clear. If I have a mental health issue, I cannot hold a license. So I know Dr. Mwinde will confiscate my license for sure. So I am never, and I'm stating that, I will not say I have an issue because of the consequences of what that means. So we've been working on a peer support program, and we are coming to the regulator with a peer support program. But that's as Kenya Airways. The issue is, it's not a Kenya Airways issue. It's an industry issue that we actually need to talk about. So that peer support program will cater for KQ, but what about everyone else who's flying in Wilson? What recourse do they have with lack of a peer support system? So it's how do we support some of these systems that are there, that are progressive, and other regulators around the world are using them. So how do we quickly catch up with where the world is going?
Whatever they share with me and disclose to me will end with me. And I've actually done it quite a lot, and it has borne a lot of fruits. And that's a space you need to create, I don't know whether it's the personality of the individual seeing the crew members, because I was telling you, when I'm analyzing your medicals, I can actually see a pattern. If a client goes to Dr. Feni, the blood pressure initially will be high and subsequently come down. An ECG, you'll pick tachycardia on this particular AME. In another one, it is actually bradycardia. I see the pattern. I'm seeing it already. So it is actually the way you open up to these crew members when they come to you, to create that rapport that they trust you, just like any other medical consultation, that they can be able to open up to you. And in terms of technology, the system which is being created as a way of even asking the crew member when they are filling the document and sending it to the AME to choose which AME will see them, and even give consent to the AME on accessing documents from another source. So it is the pilot who will choose who to see and also give consent. So that trust need to be inculcated in us as we continue seeing them. That is the only avenue we have for now. Otherwise, it's not easy for somebody to come and look at this person and realize, hey, you tell this one, my God, it's gonna be, you know. But we are doing a study with Dr. Mukizo and find out why is it that they don't disclose. There's a big study which we've already started looking at why is it. But I can tell you a quick one. They fear losing their license because of the relationship between, and they say, Dr. Mai and themselves, employer and employee. That is a quick one they say. I'm not saying Dr. Mai is wrong. She has a duty to do. Even Captain Haig here, some of them are not free with him because they know what his office is supposed to be doing. So some of them will not want it to reach to him. So those are some of the issues which we go through. And they're able to tell me this, so probably it's because you create that rapport so that they can be able to tell you some of these things.
On the question that was asked earlier in terms of how can we be able to really assist from a system perspective to ensure that we remove the redundant manual filling of forms. We have begun on this, definitely from, probably some of you might know, from the insurance, and we have been able to remove that particular claim form by up to 50%. You don't need to actually fill in a claim form every time you're going to see a doctor. This can be done through the EDI system, and you can be able to fill in your details. Definitely an area of innovation within, the airline. How can we bring that home in terms of working with KQ for the last over 10 years? Be able to remove that form. I've heard it's called M something. L70, yeah, that one. Yes, and how can we digitize it so that you don't have to really keep filling it? Today I'm here at the clinic, then next week I'm here at the same form. So that is digitized in a particular application, and you just call it, of course, with the approved credentials, definitely user rights, and of course the consent that the patient has given. And number 2 was on the item of appointment booking that came up. How can we easily just book an appointment without having to call? So from what is being done and from a system perspective, I know for us is a work in progress, probably within the next Q2 of this year, within the Smart Access app, which I know a number of us in this room already have on their phones, we'll be able to actually book an appointment with any of the over 5,800 hospitals on Smart on the particular app. So if you want to see Dr. Mwinde, if you want to see a doctor at the clinic, a doctor at the camp, just go to the Smart Access app. It gives you the doctor, it gives you the slot available. You can see that this particular pediatrician or gynecologist is available on this day and book. And that particular interaction goes back to the provider because they've been able to integrate or handshake with the hospital system across. So you're able to easily just have the appointments done. So again, coming up in Q2 of this year.
So what has the regulator said? Regulator has said, KQ, it's your problem. You deal with it. In other countries, of course, the regulator, through either the investigative agencies like the police, actually do alcohol blow randomly at the airport and at touch points. Yeah, but we don't have that here. And you know that airlines sometimes have to deal with unions, for example. So there are restrictions to how much we can do. But I think from a regulator perspective, if we did have some of these programs up and running, we would have a lot more success in terms of having this not necessarily as a solution, but as a deterrent to this menace that we are having. So it's something we'll continue to have, Dr. Mwinde, unfortunately, but from the regulator side, what can we do better? I know Dr. Mai and I are trying to run an alcohol law program, but again, like I keep saying, is it an industry thing or is it a KQ thing? Yeah, the public is flying on all airlines in Kenya, not just Kenya Airways. Yeah, so how are we protecting our public from this issue?
Probably the response is from me. Actually, since I came to the office, I've knocked on the door of the safety, the person in charge of safety at KCA, and we have actually scheduled a meeting, and we have a official communication from probably the industry players and especially the big brother KQ requesting that, because it's not a medical issue actually. It is all of, it's a management issue at KCA and needs to be channeled through the right office. I can only come in to give expert view after talking to the experts. But we have a document. We have a document which we had developed quite a while ago about alcohol policy in civil aviation. And it went through a lot of litigation issues. And I remember the legal personnel were looped in and they looked at it. And my slight discussion with the safety officer is like that was surmounted and it only needs to be ignited and made a policy. So probably we need to write and request so that they can come up with it with speed.
Contribution, the insights, and all of you for participating. In another life, I'll become a pilot because I want to be paid to sleep, to take a nap. I can't take, no, sorry, I want to take controlled rest in flight. That's better. But yeah, thank you very much. We say aviation medicine is not just about treating conditions, it's about preventing risks, ensuring fitness to fly, and ultimately saving lives. We do that at the back office, yeah, when we are clearing those patients. So I hope today's discussion sparks new ideas and collaborations in the respective areas. I'm sure everybody here has seen the role they play when it comes to ensuring safe skies, and that is the objective we had for today. So we'll bring this panel to a close, and I'll invite Leo for the next bit. Please let's give him a clap.